All right, let's jump right in. We're talking about cardiac meds today, basically the essential toolkit every clinician needs to know to support the heart. We're going to demystify these drugs, figure out how they work and why we use them. So whether you're just starting out or you've been doing this for years, let's open up this toolkit together.
So it really all boils down to this one big question, right? How do we protect the body's most vital engine when it's really under stress? I mean, when the heart's failing or it's just plain overworked or its supply lines are getting clogged up, what do? How do we step in and help that incredible engine keep on ticking?
Okay, so here's our game plan. We're going to look at this from a problem-solution angle. First, we'll break down the heart's biggest challenges. And then, for each one, we'll look at the specific pharmacological tools, the drugs, that we use to fight back.
First up, problem number 1, easing the pressure. This is really a problem of pure physics. Just imagine the heart trying to do its job, but the whole system is just overloaded. There's too much fluid and the pipes are clamped down tight. That's a ton of resistance, and that's the first challenge we need to solve. So let's really picture this. The heart is a pump, right? When there's too much fluid in the system, that's what we call preload. It's like trying to run a pump that's connected to a completely overflowing tank. It's just too much volume. And then there's afterload, that's the resistance. It's like trying to push all that water through a tiny, kinked-up garden hose. Either way, the heart has to work way too hard with every single beat. So, how do we get rid of that excess fluid? Well, we bring in the diuretics. But here's the thing, they are not all the same. You've got your thiazides, which are kind of the reliable first-string player for hypertension. Then you've got the big guns, the loop diuretics. These are potent for when you have serious fluid overload. But, and this is a big but, they can make you lose a lot of potassium. And finally, you have the K-sparing diuretics. They're not as strong, but their whole job is to play defense and hang on to that potassium.
And this right here is where clinical judgment comes in. Your patient is overloaded. You need to get fluid off fast. You're reaching for a loop diuretic, no question. But you've got to be watching like a hawk for ototoxicity. That's hearing damage. It's rare, but it's serious. Now, on the other hand, for that day-in, day-out management of hypertension, a thiazide is pretty much always where you're going to start.
Okay, so that's the fluid part. What about the resistance, the tight pipes? For that, we turn to a whole class of drugs that mess with the body's own pressure system, the RAAS. The two big players here are ACE inhibitors and ARBs. They're like two different roads that lead to the same place, relaxing those blood vessels. But here's the key difference, the one you really need to remember. ACE inhibitors can give people this nagging dry cough. And honestly, that cough is the #1 reason someone gets switched over to an ARB.
Now, these drugs are fantastic, but you have to respect them because they have some serious risks. You absolutely cannot forget about hyperkalemia, dangerously high potassium, especially if you're using them with a K-sparing diuretic. And then there's angioedema. This is a big one. It's this rapid swelling, especially around the face and throat, and it is a drop-everything, life-threatening medical emergency. These aren't just suggestions, they are critical, non-negotiable safety checks.
Another tool we have are calcium channel blockers, or CCBs. I like to think of them as the chill-out medication for your blood vessels. They basically go to the smooth muscle cells and say, hey, just relax. They block the calcium that signals those muscles to contract, so the vessels open up, and boom, afterload goes down. The heart can suddenly pump so much more easily. Just one thing to keep an eye on is peripheral edema, that classic swelling in the ankles.
All right, let's switch gears. We've talked about pressure, but that's only part of the story. Now we're on to problem number 2, slowing the pace. Because it's not just about pressure, it's also about speed. A heart that's running a marathon 24/7, beating way too fast and way too hard, well, that heart is on a path to burnout.
It really comes down to a simple concept, supply and demand. The heart is a muscle, and like any muscle, it needs oxygen to work. Think of it like a budget. When the heart starts racing, its demand for oxygen just skyrockets. If the supply from the coronary arteries can't keep up, you get a deficit. And that oxygen deficit, that mismatch, that's what we feel as chest pain or angina.
So how do we fix that imbalance? How do we calm things down? We hit the brakes. And in the world of cardiac meds, the brakes are beta blockers. They literally block specific receptors in the heart, telling it to slow down its rate and not to squeeze quite so hard. And that is a total game changer. It directly dials back the heart's oxygen demand, getting that supply and demand budget back in the black. But just like with real brakes, there are rules you cannot break. Rule number 1, and this is the most important piece of patient education, you can never ever stop taking a beta blocker suddenly. The rebound effects can be incredibly dangerous. And for us, the clinicians, the rule is just as simple. Always check the heart rate and blood pressure before you give a dose, every single time. Okay, but what about when someone is having chest pain right now? We need something that works in seconds, not hours. Enter nitroglycerin. Its main trick is to relax the veins. When the veins relax, more blood stays in the periphery and less blood returns to the heart. This lightens the heart's workload. It's like giving it a quick timeout. And you know the drill, 1 tab under the tongue every 5 minutes for up to 3 doses. If the pain's still there, it's time to call for help.
All right, next we have a real old-school drug, but one that's still around because it's powerful, digoxin. But it's also tricky. Look at this number. That's the therapeutic range. It is ridiculously narrow. That means the line between a dose that helps and a dose that harms is razor thin. It's a drug that demands our constant attention.
And because that window is so small, we absolutely have to teach our patients to be the first line of defense. They need to become detectives of their own symptoms. We're talking about things like nausea, an upset stomach, but the really classic sign? Visual changes. If a patient tells you they're seeing yellowish halos around lights, that's a huge red flag for digoxin toxicity, and they need to call their doctor immediately.
Okay, that brings us to our third and final problem, and you could argue this is the most fundamental one of all. We've talked pressure, we've talked pace, now let's talk about the pipes themselves. What happens when the plumbing gets clogged?
So we're really fighting a war on 2 fronts here. First, there's atherosclerosis. That's the slow, sneaky buildup of plaque inside the arteries, making them narrower and narrower. Then you have thrombosis. That's the acute event, when one of those plaques bursts and a blood clot forms right on top of it, blocking the artery completely. That right there, that's a heart attack.
So our number one weapon against the plaque buildup are the statins. And they're brilliant because they have this awesome 2-for-1 benefit. Yeah, they lower your LDL, the bad cholesterol, but maybe even more importantly, they stabilize the plaque that's already there. They make it less angry, less inflamed, and way less likely to rupture. The 2 big things we monitor for, liver issues and muscle pain.
Now, to fight the clots, we have a whole other set of tools, antiplatelets and anticoagulants. They work in different ways to make the blood less sticky, but they all share the exact same, number 1, top of the list risk, bleeding. So all of these precautions, avoiding other risky meds like NSAIDs, using soft toothbrushes, watching for bruising, they apply to all of these drugs. This isn't optional, it's essential for keeping patients safe.
But what happens if the disaster has already struck? A clot has formed, and it's blocking a major artery. This is when we call in the emergency crew, the thrombolytics or clot busters. And let's be super clear, these don't prevent clots, they destroy existing ones. But this is a race against time. The clock is ticking. That door-to-needle goal of under 30 minutes exists for one reason. Every single second we wait, heart muscle is dying. It's that urgent.
Okay, so we've looked at the tools for pressure, the tools for pace, and the tools for the pipes. We've got our toolkit. Now, let's bring it all home and talk about the clinician's role in all of this. How do we put these pieces together for our patients?
This right here, this is the standard of care for a patient after they've had a heart attack. And look, it's not just one drug, it's a whole cocktail. It's like a symphony, with each medication playing a crucial part. You've got your antiplatelets for the pipes, a beta blocker for the pace, an ACE inhibitor for the pressure and to protect the heart muscle itself, and a high-intensity statin to tackle the plaque problem. This combination right here is what saves lives.
So we've walked through the whole toolkit, we know the what and the why, but the real art of being a great clinician is in the how and the when. So I want to leave you with this thought to take with you. The next time you're with a patient about to give one of these meds, ask yourself, what is the very first thing I'm going to check to know this is working safely? Is it a heart rate, a blood pressure, a lab value? Answering that question, that's where knowledge becomes wisdom.